Shall we start the webinar? Okay, fine. Once again, good evening. It's a wonderful moment to extend my warm welcome to all of you on behalf of KHPT. Before we begin, I would like to express my thanks to USAID and CTD for conceptualizing series of webinars. We have organized these webinars under USAID-supported Breaking the Barriers project. So far, we have completed 2 webinars. Our first webinar titled Inequalities Within Our Cities, Expert Conversation on Urban Poor was held in the month of September. And the second webinar titled In Between Home and Destination, Expert Conversations on Migrants was held in the month of October. The third webinar, today's webinar, brushes upon the topic Drivers of Industrialization, Expert Conversation on Mining and Industrial Workers. Today's webinar presents the challenges faced by mining and industrial workers and serves as a reminder to how critical our work is. It is my privilege and honor to welcome you all to this interesting webinar. With great respect and honor, we welcome Dr. Nishant Kumar, DADG from Central TB Division, and we have Dr. Reuben Swamickan, Division Chief, Tuberculosis and Infectious Diseases, part of USAID, and we welcome Dr. Karthikeyan, Thematic Lead, and our technical specialist in Breaking the Barriers project. And I welcome all the experts attendees in today's panel. I hope this discussion proves to be a stepping stone towards our effective goal of eliminating TB by 2025. Thank you. Over to Malika, who is going to moderate the session. Malika, please.
Yes, thank you so much, Ms. Mamta, for that setting the context, and of course, a warm welcome to everybody. So like Mamta was sharing, that this is going to be the final webinar in the series that we've been doing. Our focus was really to look at specific vulnerable populations that are to be considered in our response to TB at the national level and at the state level. And today's webinar is going to focus on the mining and the industrial workers communities, which are also extremely vulnerable to TB and other health conditions. And the objective of having this webinar is to really hear out expert opinions and insights about these communities, what are the potential barriers that they face, and what could be the possible responses that people working in the sector of health and TB can keep in mind when they evolve their solutions and they develop their program strategies. So that's really the broad objective. And we hope that what really comes out of this webinar will contribute to our own work as part of the USAID funded BTB project. So thank you so much. So I would now like to invite Dr. Nishant Kumar, DADG, TB from Central TB Division, Ministry of Health and Family Welfare. Sir, over to you. I request you to kindly present the opening remarks.
Okay. Thank you. Namaskar to everyone. And first of all, I would really like to thank USAID and KHPT team to organize this series of webinars, because we all know that due to COVID, I mean, the momentum which we have gained in last, couple of years had, come to a stop earlier. But then I think through this medium, we are still keeping it, alive. And I really like the topics which are covered in the earlier webinars. I mean, inequalities within the cities. I mean, that is a very, very relevant, topic, because no country in the world is as diverse as our country. Every 2-3 kilometers, as they say, scenario change, practices change, cultures change, language change. And every district, every block has its own difficult challenge, and scaling up the effort it's very difficult. So I really like the whole effort. I would like to thank USAID and KHPT to keep the momentum which we have achieved in 2019 alive through at least whatever we are trying to do. So and actually all these activities are in line with what message we have got from the top leadership, that is our honorable Prime Minister. On 13th March 2018, from the global platform, what he said, not only to say the program but the country as a whole, that we have to end TB 5 years before the UN targets. So I'll be brief because I really want the panel. I would like to see through the panels what we exciting panel which we have. Dr. Somashekar is on one of the panel. He is the director of NTI. So briefly, I would like to walk you through what program has done so far. And I see a lot of old partners in this meeting today. And if we see from 2010 onwards, till 2015-16, we reached a plateau of notifying around 16 to 17 lakh patient every year, and every time at global level we were reminded that we are missing 1 million. But with the guidance and with the ownership of the whole effort of ending TB in India from the highest level, what has been done in 2018 onwards, we made phenomenal success. We covered a lot of ground. From conventionally notifying about 16 to 17 lakh TB cases, we reached 2.4 million last year. And the gap was reduced to just 0.3 million. And the momentum which we gained, everybody is party to it, be it central TB division, be it state. Am I audible? Is there an issue?
Yes, we can hear you now, sir. I think there was a small lapse, but we can hear you now. Please go
Okay,
ahead.
so I'll repeat that I was talking about the momentum which we have gained in the last couple of years. And the kind of synergy we developed with the state teams, with partners, with administrators. So TB was quite high on agenda, but then COVID came. And again, with COVID also, though, like any other program, TB also took a hit. It was very natural. It is still, we are going through it. It's a pandemic, not a small thing. But then, yes, we had seen that it had affected that momentum, which I talked about quite a bit. And but what we also learned that the kind of infrastructure we developed in TB was used in response to a national calamity like this to a large extent. So that kind of gives you the maturity and strength of the program, the infrastructure which the program has developed over so many years. Hard work of everyone, who is present today in this meeting, be it the district TB officers, the state TB officer, partners, everyone. I think so. That is the strength we realized. So yes, there was a dip, but then while initiatives like this, virtual meetings, keeping the thing going, and regular reviews with the state TB cells, so we are slowly picking up what we lost. And the kind of lab support which we had. We have the latest technology for diagnosing TB in India. Initially, to start with, we just have about 13 to 14, 15 machines. Now we have about 3,000 plus molecular platforms in the country, and more are on the way, more or less in sync with what NSP talked about. So the program has best possible drugs, best possible diagnostics, and we are scaling them up, and we are putting these kind of platforms at block levels and below. So the point here is whatever best is available in the world, we are trying to use in the program, and we could extend our help with these molecular tests to COVID response also. Free drugs and free medicine, diagnostics, and additional support through Niksha Poshan Yojana. These are few things which program try to provide the 360-degree quality services to TB patients. So this is in short about what we have done. Now, coming to today's topic, that is the vulnerability of industrial and mining workers, which you have very rightly, chosen the topic today, because there are certain population which have TB as an occupational hazard, or they are more at risk, be it miners and be it industrialists in the industries. So the idea was to have a comprehensive workplace policy where these issues are addressed. We at central level also have entered into an MOU with the Ministry of Labor and Employment. But all said and done, the MOUs are one thing, but actually getting it transformed into real practices in day-to-day life in workplaces. That is where we need your help. That is where we need partners' help. And most of you were present in yesterday's meeting, which Honorable Health Minister has said. So whatever I say is very less. What he has given you a bigger picture, that if we have to make it a people's movement, so to say. So I think some of us who are working with this should help us implementing whatever is being said in the MOU. It has been signed, yes, but let's have that momentum. We have definitely involved organizations like FICCI and other organizations, but a constant engagement with people who call the shots at workplaces, the HR managers. They have to be sensitized with implementing the workplace policy of so that they are basically they are TB friendly, so to say, or there should be an annual health checkup for TB, including other non-communicable disease plus other infectious disease, if the industry is having that kind of exposure. So I think with these words, I will stop here and would like to listen more through our panelists. And I would like to just remind you that expansion of diagnosis and treatment services with innovative and inclusive strategies will be the key, and we are doing it, as I said. And let's all join hand together in this fight against TB. So once again, I congratulate USAID and KHPT for organizing this webinar, and looking forward to learn new ideas, suggestions to the program. Thank you.
Thank you so much, Dr. Nishant. Thank you so much, sir. And I think the key is really to see how to keep the momentum alive and build on what has been established through the systems, which is really, really significant, as you've stated. And I think some of your inputs about working really closely with the stakeholders that are connected with the mining and the industrial communities is really critical. Thank you very much for making time to be with us for this webinar. I would now like to request Dr. Reuben Swamickan, Division Chief, Tuberculosis and Infectious Diseases from USAID, to kindly share key remarks for the webinar. Over to you, Dr. Reuben.
Thank you, Malika, and good evening, everyone. Firstly, it's an honor and a pleasure to be here. I'm listening to Dr. Nishant, talk about how this is an important area, and I think it's come at the right time. And I think, like he also said, we always speak about it, we don't do much. And I think the time has also come about that, to be able to do something for it. And I would also, like him, be interested in the subsequent speakers who not only have the experience, but also the expertise in being able to address these issues. So, I'll be looking to keenly listen to them. I just like to state a few points of general interest on, why this is important, and especially for all of us who are working in TB, and I'll not go into the details on, TB in India and stuff like that, but just to understand what's the vulnerability of industrial and mining workers, and, why it is important that they need to be engaged, right? There are currently at least 3 billion people in the world of work, which is, a little less than half the world's population. And of these, nearly 1.3 billion do not earn enough to lift themselves out of poverty. So on one side, you have a large population working in areas that they can't come out of poverty. And on the other hand, they are also then vulnerable to disease. and the most common diseases are TB and HIV in a country like ours. And so, with nearly 75% of those affected by TB being adult men and women in their productive years, they are at a particularly high risk of certain occupational sectors that they work in, say mining, construction, and healthcare, and also they people working in the informal sector where they are looking to just make a living. So I think these are the basic challenges that we are looking at to try and understand how we can take charge and bring about a change. Also remember that these workers live in cramped and poor living conditions, and that's another challenge. All right, and this, both the workplace and the place of residence, is a great area for transmission of disease. And so, in addition to worrying about workplace interventions, you also got to worry about transmission at home or in their area of residence, where they live in close, cramped quarters, and the facilities are not very convenient. And TB is a major occupational disease among industrial workers, and especially in the mining sector. A confluence of both biologic and social conditions creates what we technically call a perfect storm, where you have this interaction of silicosis, which causes a low down of the immunity, and then you have HIV and TB, and the confluence of all of these three really leads to very debilitating conditions as far as the patient is concerned. And so, among the factors contributing to the higher rates of TB among miners include this exposure to silica dust, the prevalence of HIV, and like I mentioned earlier, generally poor communal living conditions. And so, I think as TB is expanding its wings to get to not just the clinical side of things, but also to the social side of things, we've got to take all these factors into consideration, not simply just workplace interventions. I think also this whole there's a circular migratory nature of the mining industries, which means that the hazards such as TB and HIV are spread in the labor communities because of their just constant migration from one place to another, right? Not necessarily in mining alone, but in everywhere else, construction, for example, right? And circular migration, and or the location of the mines in especially impoverished, remote communities allows these mining communities or these mining companies to actually pass on the burden to the government in terms of healthcare. And we know that healthcare in these kind of areas is suboptimal, and so it's a double whammy, both in terms of poor conditions, poor wages because they are in poverty, and then on top of that they are now burdened with things like TB and HIV. And so one of the travesties of something like this is cheap labor, and how can we help overcome that? We know the government is having the DBT project. Is there something that can be done to be able to address that? And so I think this whole negligence and lack of care for people in these communities is going to be crucial to address. So I think like this, there are a number of barriers that are related to work-related concerns, and does this because of illness? It can lead to loss of wages. It could be job discrimination, and hence people then move out of that. So there's a stigma associated with this lack of money. There's no food to eat, poor nutrition. It's just a vicious cycle that can lead to morbidity that could have been addressed if just the TB was taken into consideration. So I'll stop there and just say that addressing TB in the workplace is the first step. We also need to ensure that there are essential services, that there is adequate places for early diagnosis. There are methodologies to ensure that we have treatment completion or treatment adherence during treatment completion. I think there's a whole package that needs to be made to help these individuals address TB. I'll stop there and say thank you to the KHPT team and also to the Government of India and also to the other speakers who I'm keenly interested to listening. Thank you. Back to you, Malika.
Thank you so much, Dr. Reuben. And as always, I think you've really set the context in terms of talking about the complexities around the community that is going to be discussed over this webinar. And of course, the need for then looking at a package of services cutting across the continuum of care and not just a particular solution, because the issue in itself is complex with multiple layers of vulnerabilities. So thank you so much for your thoughts, Dr. Reuben. Thank you so much for being with us. I would now like to request Dr. K. Karthikeyan, who's the thematic lead for tuberculosis and also the technical specialist for Breaking the Barriers project at KHPT. Dr. Karthik will set the context for this webinar. Over to you, Dr. Karthik. Dr. Karthik, I think you need to unmute. I'm sorry, but we cannot hear you. Thank you.
Thank you, Malika. Thank you. Still learning. Technology is new and still we are learning the new normal way. I was contemplating today, should I need to put on my mask? When I saw Dr. Nishant sir putting on mask, it was a gentle nudge to put on mask, and wherever we are, it is better to put on mask. Whatever we have learned in COVID, better we put on whatever we have learned. I'm we are grateful to CTD officials as well as USAID colleagues. They were part of us when we conceptualized these webinars. As Dr. Nishant pointed out, when COVID struck us down, no much field activity happening. In order to continue the momentum, what we are engaged with in reaching vulnerable population, we should not lose that momentum. When we conceptualize these webinar series with the whole soul and heart, USAID colleagues, Dr. Reuben, Amrita, they were fully supporting us in conceptualizing and doing these webinars. And starting from DDG, Dr. Sachdeva, Dr. Rao, and Dr. Nishant and team, they were fully supporting in this webinar series. Thank you so much, sir, and the support what we have gained through this webinar series. Not only national level stakeholders, even partners. If you see the panelists, this is an example of how we can collaborate with each other, reach union and director from NIRT. We are not independent. All of us, we have joined hands together in fighting against TB. That is an excellent showcase of how we collaborate with each other. So hats off to the team which has brought this as a reality. I was just wanted to mention one particular thing in this keynote address. I started my career as a factory medical officer. It was a well-established factory, and their policy was TPM, Total Productivity Management. That means zero stock policy. Whatever they produce, they will export it. But in that, when I was a factory medical officer, one morning before they go for the shift, an employee came and he said, I'm having a cough and fever. So as a young, aspiring new doctor, I asked him to sit down. I started examining using my stethoscope. He was totally shocked. He was totally shocked. I'm just saying I'm coughing and fever. Why this doctor is examining me? He was totally shocked. He was not ready to accept that he is having some major illness. It's putting up a steth on his back and chest itself brought him a big scare. But I was wondering, has it changed after 20 years? Has it changed? Still, for the industrial population and mining population, they don't want to be branded as sick people. Whatever they have, they want to continue to earn. They cannot afford to lose their daily wages. It applies more to non-formal employing sector also. They cannot afford to lose. They cannot afford. They don't want to lie down on the bed. They want to earn. They want to support their families. With that complexity, with that poverty and economic need pushes them to work. Is health a priority? We will have to contemplate on that. We will have to discuss and we will have to support them to get appropriate care. And all of us have joined together. Yesterday, as Dr. Nishant Kumar was saying, it was so inspiring to listen to our Honorable Union Health Minister. He says, starting from Prime Minister to the layman, we will have to take up this fight. And TB Harega, Desh Jitega should be our mantra throughout in 2021. That was his saying. I echo with the efforts what the Government of India is taking. Let us move forward. Thank you for the opportunity for sharing with you all. Thank you. Let us keep up the fight against TB, and ending TB in India is still a reality. We can achieve that. Thank you so much. Thank you, Malika. Over to you.
Thank you so much, Dr. Karthik. You almost left us with a call to action even at the beginning of the webinar. That's really inspiring. Thank you so much. So we're going to move ahead into our panel discussions, and we have our esteemed panelists with us. So our first conversation focus, or the first panel discussion, is going to be on the topic effect of industries and mining on health. Before we kickstart these conversations and hearing our esteemed panelists, we have a question for the audience. We would like to encourage all of you to please refer to the link that is going to be posted in the chat box, participate in that question and kindly respond. And even while you do so, I would like to take the privilege and the honor of introducing our esteemed panelists for this webinar, for this panel. We have with us Dr. N. Somashekar, who's Director, National Tuberculosis Institute of Bangalore. So thank you so much, sir, for being with us. Namaskara. It's good to see somebody from Nammuru, Bangalore. Thank you, sir, for being with us. We have with us Dr. Neerja Arora, a Senior Technical Advisor from the International Union Against Tuberculosis and Lung Disease, the Union, Southeast Asia Office. So thank you so much for being with us, Dr. Neerja. We really appreciate you taking your time out. We also have with us Dr. Subrat Mohanty, Senior Advisor and Project Director, Allies Project from REACH. Dr. Subrat, thank you so much for joining us this afternoon. You do come with a lot of programmatic experience, and we're really excited to hear your all of your views on this really important subject today. So I hope the participants are actively engaging with the link. I would now like to kickstart this panel discussion with my first question to Dr. N. Somashekar. Sir, the question to you would be, what are the occupational health vulnerabilities of the mining and the industrial workers? So please do share your thoughts on it.
Okay, thank you, Dr. Malika. Before this one, I would like to thank KHPT, USAID, and Dr. Reuben is already almost whatever I wanted to say, he has told. He has made my job simple. In the sense, what are the drivers he has already questioned this one also. And thanks to Dr. Nishant, because he has what are the diagnostic services, how the current program is going on, he has already told. However, vulnerability in the sense, what I want to say is there should be some exposure. Industrial workers are mining this one, they are exposed to certain things. What they are exposure to a human being or a person who is working there. So I will talk in the term. Exposure to skin is the most exposed part, what we think like that. However, as a pulmonologist, I will say that lung is the one which is most exposed. And then the GIT comes and other system. Out of that, if you can say that, because I am related to TB, lung is the one which is most exposed, and we are now working towards the TB. Reuben has already told, and Dr. Nishant has already told. If you take the whatever the missing cases, we are not able to diagnose many cases, or probably we are less concentrating on that. What I meant to say is tuberculosis among silicotuberculosis, what we call silicotuberculosis. This silicotuberculosis, just a picture of that. What is the epidemiology? If you ask me, just Rajasthan, one of the states, just I took that. Out of that notified TB cases for the last 3 quarters, around 1,09,000. In that, 498 are
notified TB cases which are from migrant or minor population. It's amount to around 0.5%. One more paper, just what it says that there is a National Institute of Mineral Health, Miners Health, sorry, from Nagpur. It says that around 6.4% of the cases, around 935 samples, whatever they have done, the chest X-ray was showing a chest X-ray lesions. So just to know the burden of the tuberculosis among them. But there, they have not done any microbiological testing. So, but it varies, maybe around 12%, 3 to 12%. That's what the confidence interval says there. Now, we'll come to the vulnerability. Why? When I told that the skin, lung, and then the GIT system. So the studies have shown that these exposed spot, it may be when it comes to the skin. One is skin is exposed to extreme temperatures. Ambient temperature may not be there in the industries where they are working. If you take in mining industry there may be heat stress and tunneling and hot climate they have to work. They are exposed to that. There is a dehydration and they are also face many problems. Like that, what about that other industrial workers like government workers, those who are working in other places also, they may not be able to access, why I'm telling you heat stroke and heat stress, in other industries also, they may not be able to get the adequate water, whatever the potable water it is required. And estimate says that around 4 liters of water should be there. An healthy person has to drink. Probably the industries may not be in a position to supply so much of water. So that leads to dehydration and electrolyte imbalance. Not only that, they are exposed to other bacteria and bacterial infection and dysentery, so on, so on. There was a study also in the government workers. There also they are told that, and they work in extreme temperature situations. There, these government workers are a cotton industry where cotton exposure is there. What happens? There is always two things are there. One is exposed to dust as well as cotton fibers. So there, the space occupied by per person may be less also, where the temperature increases. And again, I told you the ventilation. I think what I mean to say is, as we know that air exchanges, around 6 air exchanges should be there per hour, may not be that much where they are working. So only supervisory staffs or manager staffs may be having a AC and other fans and other things. So they are exposed to the vulnerable situations there. In the sense, they are more work with the sweat. In the sense, and also one of the factories in southern state where it has been found that because of the work allotted, that stress preset targets, where the woman employee was not able to take food and water. They are not able to go to this one also, because that time they want to consume in that they have to complete that target, whatever that they have to given. So when they don't drink water, again they are exposed to the dehydration. And also not only that, whether why they are not drinking water also, maybe the sufficient latrine may not be provided. As per the standards, at least one latrine should be there for 20 employees. May not be. So that could be the reason. The convenient congenial environment they might have not created for our respected female employees. That could be the reason. And also to take care of the menstrual cycle and other this one. This is what they expressed during their this one also. Next, come to the I told you about the stress. It is when the stress is there, certainly they are exposed to psychosocial hazards. When there is a stress, there may be a violence also. So our employees are also exposed to the violence. It is not only a physical, abusive, and Some people have reported the sexual harassments also by the superior authorities, and they fear and all those. This is what during the interviews it was this one. Whenever there is a stress, one more thing, they lead to the abuse of alcohol, and also it is not, it's a physical stress, not only physical stress, it's a mental stress that leads to the alcoholism, that leads to tobacco consumptions, and also economical loss also. It's ardent, it's a vicious cycle. So depression, anxiety will also come into picture. And the other system, when we, what the study says that they are having health issues related to this stress and industrial this one. So mainly GI related, or it is musculoskeletal. Mainly the top priority comes as a musculoskeletal system, in the sense the pain, backache, neck pain, ergonomics. We have to understand the ergonomics. Probably they might have been not provided the adequate ergonomic organization to sit properly. The backrest is not there, and the chairs with arms will not be there. So finger and also pain will be there, and they have to sit for a longer period. For example, if you take a garment industry, they have to stitch so many pieces of cloths, so that they are exposed. So most common is musculoskeletal. Then comes the in that musculoskeletal, I already told that the pain, neck pain and low backache is the most common. This one, and also generalized weakness and stiffness of the affected parts also will be there. When there is a stress, when they don't take the food, certainly GI system will affect. That heartburn, or what we call is gastroesophageal reflex disorders, or gastritis, or acidity, what we call that. They may take more water also. They don't think, they take coffee or tea also in between. Yeah, if the factory is providing, probably may not be having that much this one also. And when they don't take the food, what happens? When they have to work for a longer longer duration, certainly it leads to malnutrition, and it leads to anemia. They don't take a food, and there is always a stress-related insomnia, anxiety, depression. These are the things that this one. And also it has been found that when there is a stress, cardiac system also gets involved, like hypertension and cardiovascular disorders are also is there. And long time sitting or standing leads to varicose veins, or there may be a swelling in the feet. It may be due to, again, the protein malnutrition also. We may be there also. Along with that, one of the this one, when the study was conducted, so there was a stress again because of the preset targets. It was this. Apart from that, yes, migration, shifting of the jobs, shifting of the places has led to, yes, smoking, alcoholism again, and then as Dr. Reuben was pointing out, that sexually transmitted disorders, especially HIV, that's a high risk factor for our TB, that, and alcoholism, again malnutrition. It's a vicious cycle. What it goes like that, it's a nexus between like this one. And also it has been found that in northern part of Karnataka, one of the factories there, it was found that the NGOs have found, that researchers found out that there is a nexus between the factory owners and the police people and drug peddlers also. Probably we need to think a lot in this. Those who are protecting, they may be indirectly helping to the people to get into that. So drug addiction. So that is a very bad to say that, but this is what it's existing. That's what the study says that. So these are the things that are our factory workers or industrial workers, irrespective of the sex and in a sense gender, male and female. So what I mean to say is they are the one, they are getting vulnerable to the health hazardous, that physical hazardous, chemical exposure will be there, psychosocial, and also, and I would say the final thing, we cannot leave apart the healthcare workers at present. In the COVID era, it has been shown that before that also we were used to see that isolated cases of physical assault to the healthcare workers. Not only healthcare workers, frontline workers like ASHA and Anganwadi workers and ANMs, even doctors also I have seen that. In where I was working in the previous institutions, it has been observed that people used to come with a sickle to this one. So, okay, you make what I mean to say is a emergency case like that with the sickle only. I'm a witness for that. So, but this media, because of that, at present, what has happened in the COVID era, where when the people, our healthcare workers, gone to for the screening and other things, in Madhya Pradesh and even Bangalore also the incidents has happened that the people are going and beating the healthcare. It's a very bad situation, but it exists, that we cannot say that it is not there. It exists that they are also this one. Thank you so much. These are the vulnerable situations that we have to protect our people also. How to go about that? These are the risk. We are at risk. But we have to, our Rutti Dharma, what I meant to say is our profession is like that. We have to go ahead with all this. Right. Thank you.
Yes, thank you so much, sir. I think you gave so many different perspectives to this question, and you also brought in gender because you spoke about the conditions of work, and you also, gave specific examples from different studies, existing evidences, and your own experiences, and you pointed to the need of that are unique to women also, and some of them just don't get met. So that perspective is completely missing. And also the need to work with the frontline health workers and how to equip them and, protect them as well in this whole process. So thank you so much for those insights, sir. Grateful. I would now like to direct the next question to Dr. Neerja Arora. Ma'am, the question to you is, what makes industrial and mining workers particularly susceptible to TB and other respiratory problems and illnesses? So it would be great to hear your perspective on this question. And while you do so, I would also encourage all of our attendees from across geographies, please do participate. Feel free to post your questions, your comments in the chat room, and we'd be happy to take them during the course of the webinar, or if not, maybe later. We would love to revert to you. So please engage with us and leave your comments and questions. So Dr. Neerja, over to you.
Thanks, Malika. Dr. Somashekar has just told a lot about the occupational diseases, the entire universe of the diseases that may occur and how and what to do about them. All occupations and industries are linked to some health hazard or the other, depending on the repetitive work that we do, the general work environment, and the personal habit of the individual employees. So like a driver or a teacher or a doctor or even in IT industries, there are certain health hazards associated with all industries. And they range from mild aches and pains to injuries to very serious problems of the skin, of the vision, of hearing, and even certain chemical and dyes industries, people are more prone to blood dyscrasias, autoimmune disorders, even cancer. So there is a whole range, and there are even specialists who deal with the occupational health diseases. So coming to the TB and other respiratory problems of the industrial and mining workers, there's a particular class of disease called pneumoconiosis. It's a general term because most of these industries that the workers work in, it generates dust. When they inhale the dust, it causes certain kind of reaction in the lung tissue, which leads to fibrosis. And lot of minerals, lot of metals, and those working in the construction companies, or those working with ceramics or cement, so they are exposed to these dust, and they develop what is called interstitial lung disease. And most common among them, that has been mentioned by Dr. Reuben, Dr. Nishant, everyone, is the silicosis. It's a general term because a huge number of persons is actually afflicted. We don't have the numbers, they are unaccounted for, but they are there in the background, and we have to be cognizant of this fact. Now, silicosis is one of the first known occupational diseases, finds mention in ancient texts in even 4th century AD. And in India also, from the Kolar gold mines, the first recorded cases came in 1934, as long back as that. It's a progressive interstitial disease. It is not curable. Only thing you can do once a person has silicosis is to remove that person from that environment, give him symptomatic treatment, and give him sort of a rehabilitation or palliative care. So once this sets in, there is nothing that we can really do. But what is important for us is that silicosis is a very important cause of a cause or a causative factor for developing tuberculosis. When a person inhales silica, the quartz crystals, so they go in the crystals go in the lung tissue and generate that fibrogenesis, as I mentioned earlier. But they also they also destroy they impair the functioning of the macrophages. The macrophages in the alveoli of the lungs are the first one to eat up the foreign bodies, including pathogens such as the Mycobacterium TB, and they mount what is called the cell-mediated immunity. So when these macrophages are affected, they are prone to a lot of infectious diseases also, and tuberculosis is the most important one of them. So that said, like it was mentioned earlier, that person it affects TB in many ways. A person who has silicosis has 3 to 39 times more possibility of developing tuberculosis compared to a healthy subject. And, it's not only that they develop TB, but it's difficult to diagnose TB in those having silicosis, because supposing you want to take an X-ray, so the shadows of the silicosis will, sort of overshadow the lesions of the tuberculosis. It makes it difficult to differentiate. The differential diagnosis is also very difficult. When you want to do sputum microscopy, because of the fibrosis, the person is not able to bring forth the cuff, and the bacteria are not seen in the sputum. And if you want to culture, again, because the lung tissue is destroyed, there are a lot of other bacteria, other pathogen, fungi, and even NTM, non-tubercular mycobacteria. So they overgrow in the culture. So it's difficult to diagnose. And if you diagnose a person and you want to put on treatment, there are problems of adherence, because the person doesn't get relief. The symptoms of TB and silicosis are quite similar. And even though though TB is curable and that it might be getting cured, but there is no relief from symptoms. And even when you give complete treatment of TB, there is a high chance of re-emergence of the disease, because the bacteria keep hiding in the fibrotic alveoli, and they call reactivation of disease. So it's they go hand in hand, and they are very difficult to treat and very difficult to diagnose. And TB is sometimes underdiagnosed and sometimes overdiagnosed. So there is no satisfaction to the patient as well as to the physician that something good has been done. So recently, we don't even have good estimates how many patients are there, because unless we know the problem, we cannot improve upon it. If we do not know, we are not able to monitor, we will not be able to see whether what efforts we are putting, it is bringing good results or not. So very recently, in April 2020, there was a paper in PLOS One, and the scientists, they studied the miners in about 15 mines in Rajasthan, and among them, they found that 30% had history of tuberculosis. Abnormal lung findings were found in about 42% of these mine workers, and as much as 90% of them had deranged pulmonary functions. Their spirometry was all bad. So the problem is very much there. For a long time, it was getting underreported. I have been part, of the TB program in Rajasthan, and a lot of mines there. I have come across those workers and their families quite often. And for a long time, they were fighting for their rights for compensation, and it was not happening. So there are about 30,000 sandstone, marble and granite mines across 10 to 12 districts in Rajasthan, 2 million documented workers and about 8 million otherwise workers who are not documented or who are also working in the construction industry, and hence they're also at more risk to silicosis. And this disease, silicosis is very rampant there, and it is known as patthar ki bimari, the disease of the stone. Everyone knows that anyone who's engaged in cutting, grinding, drilling, polishing of stone, in due course of time, it may not happen now, but in say about when they start their work as a child, and by the time they are in their 30s, they get afflicted with silicosis. And once they get silicosis, their downfall, the deterioration happens very fast, and within a decade they are gone. So there are, if you Google, you Google for villages of widows, you'll come across lots of names of villages in Rajasthan where all the men folk have died, and there are lots of homes with only widows and destitute people. So that is the whole range of afflictions that can happen, in the industries and the mining sector. We'll talk about more, and we'll hear about this more from the next panelist in the meantime. Thank you.
Yes, thank you. Thank you so much, ma'am. I think really you pointed to the scale of the problem itself, and you just, stated some of those numbers that are quite staggering. And if you think of it just coming from one state, I can imagine what it would be like at a national level. So really, now thank you for those insights. I would now like to direct a question to Dr. Subrat Mohanty. Sir, we'd like you to answer this question for us. What deters mining and industrial workers from seeking healthcare services? What are the barriers? What is it that kind of makes it difficult for them, or difficult for them to access the services that are actually available? So it would be good to understand some of those barriers and bottlenecks. Thank you.
Thank you, Malika, for this opportunity. I'll start with my field experience. So it was a few months back, definitely before COVID. I went to a place in Punjab, Jalandhar district, and I went to a colony largely inhabited by the industrial worker. And when I went to that place, it was a one room sort of living condition, and I found that over 20 to 25 workers are in the room, not ventilated at all, and all were sleeping. So fortunately, I was with a community worker with me, and when I asked the question to them that why they are sleeping at 11 o'clock in the morning, they said that they had all come in the morning after a night shift, and they have to sleep for a few hours till 2 o'clock, and by 4 o'clock they have to leave this place because the other group will come and sleep. So this is the situation of unorganized workforce in the country. I was listening to Dr. Reuben. Actually, he raised the point that TB is not a medical condition. It is more of a socio-psychological condition. And we all know that, the mining is a job known to have high risk of injury and also disease. One of the biggest challenges, because you asked me about the barriers and other things. See, is basically when an industrial worker, a mining worker, he or she feels that there is some problem with the health, they normally hesitate to go out and reach out because loss of employment. If they reveal the fact that they're having some issues, some health problem, that could spread out and go to the contractor, who will be like, say that, stop coming to work because we have abundant labor force in the country who can come and replace you. So sensing the loss of employment, they normally hesitate to come out and operate. For a female worker, coming back to I listened to Dr. Somashekar and even Dr. Neerja also raised that point about the sexual health diseases, sexual transmission, other things. They normally never reveals around the family or the community because of stigma. And that stigma actually, for one thing, is that people will get to know. And the other thing that once they get to know, it will be transmitted to the knowledge of, again, the contractor, the managers who may throw them out of the work. Loss of job is a serious issue in the organized sector, in the mining area, in the industrial worker, with the industrial worker. Access to services, access to healthcare. You know, there are big companies, big industries where at least you have a setup, you have something organized. We have a system of medical care. But there are many industrial setups, there are many mining areas. You will not find a structured healthcare system. Even if you go and talk about your issues, doctors may listen to it, but will not provide any solution. It means they have to go out to other places. In that case, they also have to take leave. And then again, the question of loss of job. Poor living condition I touched upon. Stigma. Although when people say that the stigma is not around the industrial worker or the people who are engaged in the job in the industries, but still there are stigma because they live in the colonies, they live with their families, and they know that, for example, say TB, if they're coughing and they say that I'm coughing and it could be TB, it could lead to TB, then there are serious issues of stigmatization. That person will be thrown out, that family will be asked to leave the place, which leads to all sort of complications and loss of job also. The facilities available around the industry and the mines, absolutely not available. And finally, you know, the available of workforce, the migration, the inflow, outflow of people from industries to industries and from states to state, district to districts, it has also complicated the issues a lot. I mean, there are a number of examples in the country, and even I have met many of the doctors in the company, in the industries, whom I have asked the question that why. They said, you are asking a question that they don't come to us. If they come to us in a very late situation where we do not have anything to say. They don't come to us because they know that the fear of stigmatization, they know that there will be a loss of job. So these are some of the issues which have complicated the issues around public health and also tuberculosis. And tuberculosis largely because the earlier speakers talked about silicosis, tuberculosis, and there are a number of studies around that, how it has affected to the industrial worker and miners. And there are a couple of laws also. And who reads that rules? The companies? No. The manager? No. So we need to look the situation, the problem, unpack it, and see that where we can pitch in, how to address the issues, and why the industrial worker and miners are not coming to the health center, not come out to show their diseases, the issues in terms of health. And we all need to address several other social determinants of health in order to address the tuberculosis in public health. Thank you so much, Malika.
Yeah. Thank you so much, Dr. Subrat. I think you've drawn our attention to a whole lot of barriers that actually prevents the workers from accessing care, accessing services, and all of this really contributing to delayed diagnosis and delayed treatment, which is really what I think most of the programs that are working on TB are trying to sort of grapple with, and trying to bridge that gap, trying to reduce the time in terms of delay. Of course, you spoke about stigma, you spoke about migration, which is also something that we touched upon in the series that we did on migrants. And I think that really stood out for us as a huge gap and as a big potential for us to work on in future. So thank you for those insights. So with those remarks, we come to the end of panel 1 of today's webinar, which really tries to explore the effect of the industries and and mining on the health of workers, specific focus on TB itself. So we will move on to the next conversation focus, which is the role of the industries, the government, and the community. But before we kickstart our second panel discussions, I would like to request our Tinker Labs team to kindly display the responses that have come out as a result of the audience participation. So to the question, what according to you is an occupational hazard that affects the health of industrial and mining workers? So there are things like environment and dust, difficulty in breathing, dust, respiratory diseases, the nature of the occupation itself. So I think largely a lot of audiences, a lot of our attendees have spoken about dust, and I think Dr. Neerja did touch upon dust, spoke very clearly about silicosis, patthar ki bimari, and of course there are so many other factors that we heard about, in terms of stigma, the kind of stress, the harmful living conditions of these workers that even our our other panelists, Dr. Somashekar and Dr. Subrat, touched upon. So yes, I think there are several factors and several ways in which occupation impacts the health of the workers in the mining and in the industrial sectors. So thank you so much for your participation there, all the audiences, all our attendees. Thank you so much. So we're going to move ahead. We have about 30 minutes before we wrap up this webinar. So we have one panel discussion to complete before that. And I think we're doing really great on time. And thank you for all the participation in the chat. I also saw a very interesting input come from Dr. Yogesh from World Health Partners, which was very interesting. He spoke about World Health Partners' experience in engaging with link workers, which means they basically have identified one link worker from amongst the community of the workers working in a particular factory or a setup, who plays the role of linking the workers to services and doing like a first level sort of reach to them, which is a very interesting community based sort of approach. We'd love to know more about it. Dr. Yogesh, thank you so much for sharing that input with the team that's on this webinar. Thank you. So we'll just move ahead to the second panel, which is on the role of industries, government, and communities in terms of actually tackling some of these challenges and these barriers. So I would like to now direct our first question to Dr. N. Somashekar. The question is, sir, what are some of the existing community level support systems that the mining and the industrial workers rely upon? So that will be really interesting for us to know. What are the kind of networks that they're a part of? How do they support each other at their workplaces or also back in their communities when they return from work? We'd look forward to hearing your responses to that, sir.
Okay, thank you, Dr. Madam Malika. I remember 1 year back, a joint monitoring mission was going on, where DADG and myself was there in Assam. There, I think Rich is the one partner which worked with the tea industries, tea estates, Tinsukia and other districts. He visited. It's a community-led model. The thing is, those who are affected, they themselves should come out. They have to raise their problems. And then only, unless there is a community involvement, it is any program, it is going to be difficult to eliminate any disease, take for poliomyelitis or TB, whatever it may be. So taking that into example, that how it was worked that time. So not only for the treatment adherence and referral, and we requested that time from the program that the industrial, whatever the tea garden, the owners also, they also have to take a part of it. For example, for the diagnosis and other this one also. So Rich was there. I remember, if I remember. Sorry if I forgotten. Ramya has to correct me. Like Ramya is there. Now, like that, this mining industry or whatever it may be, if you take an history in the 19th century, when the people were affected economically, those among the people, those who are affected by these mine workers, there was no structured healthcare system there. They fought it. when they fought it, it was found that not only a financial well-being, it is the health. Health is also an important, not only health of the individual, the person who is working, the health of the family also has to come into picture. So that is the beginning how it has happened, the workplace, coal miners, this one, that there should be now there is a legality that wherever the certain number of people are there, Dr. Karthikeyan was also mentioning, he was first job was a factory medical officer, like that. So there should be an health establishment should be there, in the sense health center should be there to take care of the health of the people. So that's how the attendance and the minor ailments or it is related to the diseases itself or exposure to that whatever the occupational hazard that they have to take. So this is how a friendly society or union has to take care of that. Considering this, there was a community-led this one also in the Tamil Nadu. There, self-help group, a community-based organization, what they did is the educating the people there. In a sense, an intervention is short lectures or a musical storytelling activities, role plays, and short film on the TV was shown that, and it has led to the increase in the referral of cases. So that is a very, in a sense, when the people aware of that symptoms are there for the TB, this is the symptom of TB, then themselves will come. So not only that, those who are involved in that STG group, they themselves will take the patient to the doctor, and once they are sensitized, this is a TB model sensitization, how they have shown us. So that is one for referral, not only strengthening the prevention and control activities also, that is the adherence also we can use when the people, they themselves come, no? It is more acceptable, the community acceptability is more among that. So another example that when it comes to the union itself, that Mazdoor unions and other this one, when they are managed with probably now certain companies or industries, they will not take that, they outsource to the contract workers, and they negotiate and other things. They will not be eligible for the whatever the full benefits are there. This Mazdoor union, when they approached the management, that they got the ID cards, they got the health cards, and very important is a safe working environment for that, helmets and other safety shoes and gloves. Yeah, before I forget to mention, now we have to use a PPE wherever there is chemical exposure, and also among us, in a sense, national reference laboratories and IRLs are already equipped with that. It is before this COVID itself that PPE is a must. However, where there is a chemical exposure, even minors also, I forget to mention that wherever there is a dust and other minor, Madam Dr. Neerja Madam has already mentioned about that. There is a legal bounding is there on those people that they have to provide the PPEs. FFP3, or it is not only FFP3, that's higher version advanced to that itself, that chemicals and noxious, the chemicals also has to be protected. So that whatever our at present healthcare workers, then now we have to use that, they got it like that. When there is a question, there is a rise from the community itself. So these are some of the examples that precarious workers, how they got it. Then there is an example of Mohanty coal fields also, contractual transports, this one. They also raised this one, and their wages, in the absence also, they should get the wages and allowances. So that's how this public health sector, coal industry also, that has got that. Just to mention that not only these, in terms of wages, in terms of medical care, there is a legal bounding also for all minors and other things. They should have a hospital, an ambulance facility, at least they should have a first aid care also. They should have a, before this, any employment, pre-employment screening and post-employment screening. This is the one routine screening there is a guidelines also and rules also that certain for example, eye checkup is a must for those who are operating lift trucks, those lifting this one vehicles. And also ergonomically, as I was mentioning, when they are lifting the weight, there is for males it is 50 kg, 30 kg for females, like that. And how to do that, the training is also important, that the gravity should be center, so they should not lift more than that. So those are the things, the guidelines and the training and supervisors, that whatever the labor ministry or factory supervisors are there, they should be trained. Not only that, there is a certain people among the field itself, in the workers itself, they have to be trained. Like that, the occupational, that mining unions also, there is a legislation. Only thing is, we have to see that in a letter of spirit, whatever it is, they should be implemented. And before forgetting that, even periodic health checkups also there for our healthcare workers, that we have to mention that. And ergonomic standards we have to follow. Silico tuberculosis, Dr. Subrat or Madam has already mentioned that. So anything which is pneumoconius and other things, there is a periodic checkup for chest X-ray has to be routinely done regularly, and also pulmonary function test. And also, just to mention that the paper where what I was quoting for that, there is a minimal exposure is there for silica. There, the Indian standards is around 0.15 milligram per meter cube. Wherever they urged that, what the researchers has told that the exposure among that 6.4% X-ray TB cases among silica dust, there it was mentioned that 0.11 to 0.16. So probably 0.15 is upper standard. So probably the occupational standards that we have to reduce that silica exposure, such that certain things that we cannot reverse it, we can take a preventive actions. These are the certain things that have to take care with the standards and legal formalities, and also routine health checkup and active case finding. Certainly, yes, it may help those who are there. There is one syndrome is there where that is a sickness absenteeism, in the sense where those who are ill, they will not come for the work. They will be in the house, or they might have retired. The compulsory is moved out. Probably that list we have to take, and we have to go to them, and we have to screen them. It is not only workplace screening, it is the household where they are staying that we have to take care. Thank you. Probably the Malika is looking at me. Probably time is
No, thank you so much, Dr. Somashekar. I think that there was so much that was packed in your sharing. And just for the benefit of our attendees, I'd like to just tie some things together. I think you touched upon the fact that there are already structures that exist within most of these communities, like there are unions, there are SHGs that these workers are a part of, and other formal and informal groups that have actually taken the leadership to press for the protection of their workers and also demand for services. And thank you for those specific examples that you gave us from Tamil Nadu and other places. We would love to refer to them and learn from them. And it's very interesting to see that there are already guidelines that, that are pretty sound, that actually talk about the things that need to be done and followed by the factories and by the employers. The key thing is to ensure that the communities demand for these guidelines to be followed, and they're educated about what their rights really are in their workplace. And that was very, very insightful, Dr. Somashekar. Thank you so much. Once again. So before I move on to Dr. Neerja, I would like to draw the attention to all our attendees to a link that has been posted in the chat room. It's a question, it's our second question for the audience. The question is, which of the following do you think have the maximum potential to create impact in the lives of the industrial and mining workers? Industries, is it the government or the community? So it's a poll. Would request the attendees to engage with the poll and kindly respond. And I must go on record to thank and to acknowledge the efforts of our wonderful partners from Tinker Labs, the team that has been working hard behind the scenes. So thank you so much, Tinker Labs team, for the great work that you all have been doing and really helping us pull off these webinars. Thank you so much. So I'm going to turn my draw Dr. Neerja's attention. Dr. Neerja, the question to you is, what have been some of the government's interventions to meet the healthcare needs of the mining and the industrial workers? And it'll be great to hear from you on some of the successes in terms of these initiatives, and also some of the challenges and some of the learnings that we can sort of, understand from these experiences. So
Thank you,
over to you,
Malika.
Dr. Neerja.
Thank you. And I'll take it forward from Dr. Somashekar, and I'll speak in, in my, what I'll talk about is in 4 sections. One is I'll talk about the global and national efforts and legislation. Then what are the enforcement challenges? What are the success stories, and what is the way ahead, as you just said. Okay, so now we know that silicosis has, it's responsible for substantial morbidity and mortality. It causes enormous economic loss to the nations as a whole and industry in particular. It is a preventable disease. It can be totally eliminated. Therefore, in 1995, the World Health Organization and the International Labour Organization began a public awareness and preventive campaign to eliminate silicosis from the world by 2030. And many countries have reduced incidence of silicosis by appropriate measures that Dr. Somashekar just mentioned, enforcing better working condition, use of PPE equipment, use of wet drilling machines, and instituting health surveillance and better health care. So all these were put in place, and in many countries, it's at the brink of elimination. India was not, it was not a fast mover in this respect, but there have been legislature and there have been laws pertaining to this since a long time. And there is a Mines Act in 1952, the Factories Act in 1948. There is a Employees State Insurance Act 1948, and Employees Compensation Act, which goes back to 1923. So under the statutory provisions, again, what Dr. Somashekar mentioned, the industries are bound to ensure that there is establishment of occupational healthcare center. There is employment of an occupational health specialist in their premises, and that specialist is or physician is trained in the use of ILO classification. There is pre-placement examination, there is periodic medical examination, comprehensive health surveillance program has to be implemented, and also monitoring of airborne respirable dust level, as he just gave the values and how they are important. But there are a lot of enforcement challenges. While, you know what, there are too many agencies working, and they're all working in silos. So while the Mines Act is under the union list, the Factories Act is under the state list. And while, all these responsibilities of occupational health and safety, health surveillance, diagnosis of silicosis, compensation, rehabilitation, all these are responsibility of the industry, but failure to detect silicosis or other uh, occupational health issues does not constitute an offense. So there is a lack in enforcement, and there is not they're not much data forthcoming. There are not any large scale epidemiological studies, and whatever official statistics we get on morbidity and mortality, they are either not available or they are just the tip of the iceberg. And also there is the challenge of eliminating all these diseases, say silicosis in India, because there is a huge informal, unregulated sector in the industry, which is not entitled to any statutory protection. The migrant workers move from, their hometowns to the mining areas, and they move from mine to mine, and they are not registered. They have no documents. They have no health cards. They cannot establish their identity. They cannot establish the linkages to the mines. They cannot claim any support. So there are a lot of enforcement challenges. So this was the situation which was going on for a long time. In 1999, the ICMR conducted a sort of survey, and they gave us some figures to go by. They estimated that in India, there were about 3 million people who are at high risk of developing exposure to silica. And again, this is discounting the numbers which are unlisted and from the irregular section, or those who are working in the construction industry. So that numbers would take this 3 million to many folds, at least 4 or 5 times. Again, multiple organizations are working. at the central government, at the state government. Then the industries are themselves responsible. There are research and academic institutions who have the responsibility, compensation commissioner, and several NGOs, but they're all working separately. So there are major gaps, and these major gaps are: there is lack of coordination amongst the stakeholders. There's no central task force. There's no central registry of cases, say cases of silicosis, which is so important. There is inadequate enforcement. There is no accountability. There is lack of services, sufficient health services. There's lack of health surveillance. There is lack of awareness among workers, employers, doctors. And there is, the entire small scale and unorganized sector does not come under the purview of the legislation at all. And furthermore, our primary healthcare physicians or a public health physicians or a NTP program managers, they are not trained to manage the occupational health disease. So in this background, some success stories have emerged. I'll talk about two success stories. So now like I said, the NHRC, after the ICMR study, the NHRC, now when I was working in Rajasthan, as I told you, around 2008, 2010, there was a lot of flurry in the media and the NGOs, and there were a lot of petitions filed with the NHRC. And they directed the governments of the state and union territories of India to provide complete information about measures that they are taking to prevent and eliminate the problem of silicosis. So several studies have also come up, and so we have some sort of data to go by. Acting on the NHRC recommendation, some positive steps were taken in the state of Gujarat. They conducted a comprehensive survey of the organized and unorganized industry who were at risk. They took a decision of providing free diagnosis and treatment at all levels of healthcare, providing counseling to the patient on how to avoid dust inhalation and how to prevent progression of disease. They developed some information material printed in local language, and they set up some silicosis health units in silicosis risk districts where free chest x-rays and pulmonary functions were done. And regular inspections were made of the industries, and there was active involvement of the NGOs to ensure proper monitoring. Coming to Rajasthan. So I attended a conference which was organized there, and the point was that even though we have all these laws, even though we have the Employees Compensation Act, till about 2009, not a single employer had been penalized. Nobody was able to establish an employee or employer relationship for any patient having silicosis till then. And then the situation took a turn in January 2010 when the NHRC, it took an action on the petitions filed by the actors and the media and directed the Rajasthan government to start action to identify patients with silicosis. So in 2012, the Rajasthan State Human Rights Commission, they announced a compensation of flat compensation, 1 lakh to any person who was diagnosed with silicosis by government appointed doctors. And any person, if such certified person dies, the family gets a flat rate of 3 lakh rupees. So I want to point out that after this, in 2013, 6 government medical colleges, they established pneumoconiosis medical boards for medical examiners. So for medical examination. So while till 2013, there was not one case certified as having pneumoconiosis or as having silicosis, between 2013 and 2017, 4 years for which we have data, more than 10,000 miners and stone carvers having silicosis were benefited from this compensation. So when when legislation was there, there were challenges of enforcement, but when the government woke up to it and actions were taken, so this was, to some extent, this problem was addressed. So what we see ahead from here is that despite lot of clinical and operational challenges in the management of silicosis and silicotuberculosis. Why I want to say silicosis again and again is that when we prevent silicosis, we prevent TB.
TB.
And when we manage silicosis well, we, in patient having tuberculosis, then we are giving respite. And because we have a stake in the TB patient, we also have a stake in the patient who are at risk of developing silicosis. So this gives us an opportunity to the government of India to have comprehensive policy framework for prevention, treatment, rehabilitation, compensation, and follow-up of these patients. So we need a multi-sectoral approach where various ministries, labor, health, mines, Ministry of Industry, state governments, research institutions like ICMR, CSIR, all these have to come together to mount a response. At the industry level, what Dr. Somashekar pointed out, prevention and early diagnosis of silicosis has to happen there. So they have to make PPE available, make wet drilling available, have linkages with digital X-ray, CT machines, mobile vans, and ensure ACF activities. At community level, again, it was explained and detailed earlier, we need awareness campaigns. We need to sensitize our workers. We need to, we need to link with the NGOs, because they are the ones who can help us in awareness generation. They are the ones who can help us in monitoring and implementation of compensation program. Even the compensation mechanism is so complex that the workers need some help, and the NGOs and communities can help them there. Now I come to the last point, what the NTEP can do. And this was a question by Sanjay also. And so see, the NTP has counted minors amongst their key affected population and amongst the vulnerable population. They are vulnerable because they have increased risks of exposure to TB, because they work in unventilated and crowded settings. They have limited access to quality TB services because they're working in remote areas away from their homes and not having access to diagnostics. They're also at risk of TB because of the biological factors, like I mentioned, having fibrosis in the lungs, having the macrophages not working, and having behavioral factors such as being there is poverty, there is malnutrition, and they also have more, again mentioned earlier, use of tobacco, use of alcohol and drugs, etc. So all this makes them very, very much vulnerable. So the program recognizes, Dr. Nishant also mentioned, and it is prioritizing the minors for the ACF and TB care activities with more focus on treatment adherence and also rehabilitation and palliative care as needed on a patient-to-patient basis. But we also need a comprehensive guidance document and capacity building of public health professionals, including those working in NTEP. In this background, and recently how the program has supported to mount the response to the COVID epidemic, because COVID is also affecting lungs predominantly. So we are now looking at the program at going beyond the TB prevention and care and supporting the entire domain of lung health, including pneumoconiosis and other such diseases. With this, I rest my. Thank you.
Thank you. Thank you so much, Dr. Neerja. And I think one of the things that you also spoke about in the Rajasthan experience was about how so many different stakeholders got involved. And I think that is also a critical point in terms of advocacy, right? I mean, having the media involved, drawing people's attention to the pressing issues that are faced, and also, sort of groom the community to act as a pressure group in the sense of really sort of, highlighting their issues and drawing attention of the policymakers and implementers, as well as their employers, to what they really need. So that was really wonderful. Thank you so much, Dr. Neerja. Very, very insightful experiences that you shared. We're going to the last leg of the webinar. So I'm just going to direct the last question to Dr. Subrat. Dr. Subrat, we would love to hear from you. What do you think is the role of the industry in the health and the well-being of mining and industrial workers? We heard the community, we heard what the government has done and the potential that it has to still strengthen those efforts. What, according to you, is the role of the industry itself? I think we've touched upon it briefly, but please, would love to hear more from you.
See, Malika, thank you again for the second question. I really like the word of the statement of Dr. Nishant. He said, let's transport into practice. We have systems. We have what you called as comprehensive workplace policy. Sri, for example, through the REACH call to action project 2-3 years back with the USAID support, we started this employer-led model. And, I remember in those days, even Dr. Somashekar was talking about tea garden and making the tea garden join together for the elimination of tuberculosis. And we could make it a dent because we involved the organization involved all the stakeholders in the state and the districts level, including the national TB elimination program, so that they could sign a letter of implementation and move ahead. But again, I said that that's again a letter of LOI, which you say. So now we have to move from the LOI to practice. And now we have to see that how industrial setup, how the mining authority can translate all those points mentioned in that workplace policy into action. Unless it is translated to action, it will remain as a sort of a slide, or maybe a sort of hangout somewhere written that there is a workplace policy in the organization or in the industry. We have a system like, for example, in an industry, if I remember correctly, that if you have over 500 workers, then there is a responsibility of the employees to see that they will provide doctor, nurses, and all the facilities to the population in the catchment area, and to also the worker they serve in the industry. But that's not happening. And nobody raised that point, no issue, nobody actually demand for it. So I again like the question, the point which raised by Dr. Yogesh in the chat box. I say that you have to make community within the community. We have to create some members in the community who can be educated, who can be really make an advocate to fight for the cause of the industrial worker who are not served, who should be provided all the facilities which are supposed to be given to them. Even for silicosis, I heard Dr. Neerja and Dr. Somashekar also talking about silicosis. So there is a provision. There is a provision for the employees to facilitate the process for the screening for the employees for the TB and silicosis. They are not doing it because if a employer or a worker found to be a silicosis affected, then they have to pay compensation. It's a question of money, and they don't want they screen for the silicosis, and so that they pay money to the worker. So there are a lot of challenges inside the industrial sector, and particularly for the employees. So what we need to do, we need to know who are in the industries. Is basically, if you look at the people who are directly dealing with the employees, they are the HR managers. They are the senior official in the industry. They need to be oriented. They need to be sensitized. They need to be told that what are there in the guideline and what they have to implement. How they can contribute to the effort and support of this the people who are working for the company. That will make a inroad to the changes around the company out and everything. Involving community, I touched upon, and lack of enforcement. So there are so many things are there in the company law and the guideline and everything. Somebody has to really put a finger and say that these are there and we have to enforce it. And that somebody actually are the HR manager, that somebody are the employees who also need to be told by the community, saying that these are for them and they should not be deprived of the services available for them. Otherwise, it will be only in pen and paper. It will never be transcribed into action. So I would strongly suggest that with all the brilliant the panelists and all the people participants here, that let's make out an effort to see that whoever working where, if the World Health Partners working with the community, with the industrial worker, REACH working with the employer-led model, and also looking forward to reach out to more number of industry. We all need to see that how we can sensitize at different level, at the highest level with the employers and managers, at the down level with the community, so that there is a balance between the two, and we can solve better. So I stop over here, and if there are any questions, I would like to answer. Thank you so much, Malika, for giving this opportunity.
Thank you so much, Dr. Subrat. I think once again, you brought in the issue of accountability, right? I mean, everything is there on paper, but the key thing is really ensuring accountability of the employers and the factories and the ones that actually engage with so many millions and thousands of workers across the country that work in hazardous conditions. So thank you so much for that. And also the need for work at both the supply side and the demand side. So those are really, really important, I think, perspectives for those of us who are on this webinar, and also those of us who are working in the field of TB and really looking at addressing issues and barriers that are unique to the vulnerable populations like the mining and the industrial workers. So thank you so much for those insights. And we've really we've run out of time. We've overshot by about 6 minutes. We have a couple of audience questions, and we hope to get back to the audience with our responses over an email to those questions. Unfortunately, we're not able to take it live on this webinar for lack of time. But just before we wind up, let's have a quick look at the results of the poll to the question that was posed to all the attendees, which was on what they felt had the maximum potential. So there you go. I think majority of them think that the industries have a huge role to play in ensuring that their workers are protected and that their health rights are safeguarded. And of course, they have sort of reinforced their faith in the communities also in terms of being a key stakeholder in this entire process. So that's what the attendees feel. That's what our audience feel. Thank you so much to the audience, and my sincere thanks to our esteemed panelists. Thank you so much, Dr. Subrat. Thank you so much, Dr. Neerja, as well as Dr. Somashekar, for being with us, for making time out of your busy schedules, and of course sharing those really, really deep insights on all of the questions. We hope to take these conversations forward, and we hope to touch base with you in future as KHPT implements the USAID-funded BTB project. And I'm sure that all of us together as a community of people who are working for the rights of vulnerable populations will be able to, contribute to the goal of ending TB in our country. So thank you so much. My hearty thanks to all the attendees, the participants, all of our partners, BTB partners who are here with us on the call, CARE, World Vision, TB Alert, thanks to REACH, several other organizations like WHP working, and of course to the constant support of all our mentors from USAID, Dr. Amar, Amrita, and Dr. Reuben. Thank you so much for all your support. And of course, our own team that has worked behind the scenes, Tinker Labs team, KHPT teams, thank you so much. And we'll end this webinar now, and we hope to keep connected on this important work. Thank you so much. Thank you, everybody, and have a nice evening. Thank you.
Thank you. Thank you.
Thank you.